Good afternoon. I'm Dr. Mwenyalungwabungu, and I welcome you to this ECHO presentation. Joining with me in the hub is our didactic presenter, Dr. Suilanji Sibile, and we have Chatonda, who assists us with IT, and Etambuyu, our ECHO coordinator. We also do have some of our colleagues joined with us in the hub from University of Maryland. Thank you, you're welcome. So today we'll be having an interesting topic on optimization of second-line ART, even as we know that we transition most of our patients to DTG-based regimens, that's TLD, TAFED, and even our children. And now we are still seeing people failing in this question. So we have an interest to be led by Dr. Suilani Sibile. We also have other experts on the call. That's Dr. Peter Matibula, Professor Lloyd Mulenga, Dr. Sombo Fellowship, and Mr. Davis Kampamba, who assist with answering some of the questions that we'll have in the chat box, and they'll also contribute to the discussion. After our didactic presentation, we'll have a short question and answer session. Then we'll go into a case presentation from Nalolo. This is by Mr. Confucius Mwemba. I hope. So without wasting much of your time, I'll allow Dr. Sibile to present. For those that will have questions during the presentation, please don't hesitate. Go ahead and post them in the chat box. We'll try and address them during the session and at the end during the question and answer session. Chatonda, are you able to share the presentation?
The answer is no. So we cannot be heard.
Okay, now I can hear you. This is Chatonda.
Can you see us? We do not know. We are not. Okay. We'll start with the poll. The first poll is Jane, female of 24, was initiated on TLE 3 months ago. Following a new diagnosis of HIV-1, he was later switched to TLD due to a virulence-induced rash. Is Jane on second-line ART? I think we just wanted from a point of semantics so that at the end, we should all be referring to the same thing. Okay, Chatonda, you can help me with the poll. We have about 42% people have polled. 50%, we usually pick the 50% as the end game, the end point. So a lot of people feel Jane is not on. You can end the poll for us, IT. Jane is not on second line. The answer is no. That's what most of the people feel. We'll probably see as we move the slide. Yeah, so the answer here is Jen is actually wants to go to second line in a way. It's actually a terminology that is imprecise. Everybody is trying to or you really the second consignment of the drugs that you have once you've been other, especially where people can't hear us. Sorry, us. Thank you. I think we can move on to the Can you hear me now? I'm using a different laptop now. Okay, we'll proceed.
Yes, we can hear you loud and clear, thanks.
So this is our second poll question. I hope I can be heard. Chatonda, I just want to make sure that I can be heard. Can you hear me?
Loud and clear.
Thank you. Though we can't hear from this side. So again, here you have an individual who had treatment failure to TLD, and he was previously on AZT3TC and efavirenz. He has resistance to NNRTIs, NRTIs, and INSTIs. And what is the best option for his second-line therapy? So we can see that this individual is not resistant to PIs. We are going to see the genotype for this individual later on. Yeah. I can see that a number of people still think it's AZT3TC and darunavir. So just for you to note, we would advise that the individual is probably put on, it doesn't really matter whether it's A or B. If I was taking care of this individual, I would put them on A. We can go to the slides. Slides. Next slide, Chatonda.
Apologies, network. So we're still having challenges in the hub with internet. So we keep switching devices, but we hope we'll be able to have stable internet in the next few minutes. Then Dr. Sibilo will go on with the presentation. Dr. Chansa, you've raised up your hand. Dr. James Chansa.
Yeah. Let me check, maybe it's me.
Dr. J. Chansa. You can go ahead. Okay, thank you. Probably it was a mistake. Okay.
Can you see that? Optimization is option. Okay. Okay. Go on. Can you switch on your camera?
Can they hear us now?
Yeah, we can try. Can do it. We can try. Check if they can hear.
Can you hear me? We have internet problems in the hub today.
Yeah, she can hear.
Okay. All right, we'll proceed.
Oh, this is changing.
Okay, so we'll rush through the slides because of time. So these were the objectives. Yeah, so like I said, the definition is imprecise of second line, and we are trying to move away, but really it's just the second consignment of ART regimen that an individual receives in their treatment journey. Reasons for switching can vary to second line, which increase treatment failure itself. There can be toxicity, and sometimes the drugs are not available, then you give different types of drugs. Because of the data is difficult to capture, because right now we have a lot of patients who are actually on first line regimen, if you call it that, but they are actually on second line. Those are the patients who were moved to TLD, but they had failed TLE or AZT3TC nevirapine as their first line. But as you know, TLD becomes their second line in that case. So just to emphasize that the type of medicines or ARVs that you are taking does not really may not be used to the fact that you are on first or second or third line, especially now that some of the third line regimens are used in first line, they're used in second line, and so on. So obviously people are put on second line because of treatment failure, and these are the reasons why we have treatment failure. A lot of discussions on treatment failure, and the causes as shown. You have patient factors, drug factors, and systems factors. We do not see a lot of these systems factors like stockouts at the moment. Now, it's very important to look at treatment failure in terms of there's a feedback. I hope there's no feedback because we can hear the mic from the next room. It's loud. Yeah. So treatment failure can be due to drug resistance, and sometimes there's no drug resistance at all, but you do have treatment failure. And obviously you use viral load monitoring. I'm getting a feedback. Please, IT, help us today. We have a feedback. I don't know which other machine is I think it's a,
Saying the slides are not moving again.
Dr. Sivile, I'm sorry to interrupt, but your slides are not moving.
Peter, please check your machine. We need to see another computer machine. Okay, you can check. Yeah, it's the internet. Okay.
okay, let me just, maybe you can help me with a different machine so that I can see the slides moving. IT, so help me with that machine so that I can be seeing the slides if they're moving. Okay, thank you. So that I can know where I am. I hope this is better. And help me stop the sound from the next room for the feedback. Okay, I think we are slightly better now. So this is our viral load monitoring algorithm, which we are very familiar with. Just to remind everybody that we are concerned with a low level of viremia as well. Once someone has got that low level viremia between 20 and 1,000, we still need to put them on some enhanced adherence as well. But you do not move them from DSDs. So just to show that we do have some numbers on low level viremia, and a lot of patients have that. So before you switch to second line, we encourage or recommend enhanced adherence. And we know over 70% of those that go through enhanced adherence will be suppressed. And this is the protocol. We would like that everybody is classified, whether they have a cognitive, a socioeconomic, or behavioral, or emotional problem. And this should be handled as we've discussed before on this network. Yeah, so this is the process itself. You need about 4 sessions, including the first one, and at the end you need to redo the viral load and to make sure that they are suppressed. If they are not, you go ahead and do a genotype and you switch them to second line. And so we know that even after repeat viral load, a lot of people will be unsuppressed, but very few individuals are being moved to second line. So there's a delay, which is really not our desire, and we hope that a lot of people are moved to appropriate therapy. You can see that we still have like around 40,000. The number should be much, much more, but there is less movement or change in therapy, even in those individuals that qualify. So there are some considerations on treatment failure. Just to say, those who have very high viral load may not have resistance, and treatment failure itself may not be equal to resistance. We've discussed this. Yeah. Consider in those that you are about to switch, you've made a decision to switch. These are some of the things you need to do, or those that are reinitiating care. Remember, adherence counseling is the cornerstone of treatment, even at the point when you're switching to second line. We encourage a welcome back package. We are going to hopefully have a dedicated presentation on how to give this welcome back package as a program. So this is one of the focus for this year. We know that some implementers have designed, but we will give a national welcome back package on this call. So those implementers who have these packages running, it needs to be implemented. We cannot overemphasize on the welcome back package. Advanced HIV disease screening should be done at that point as well. So why do we switch to second line? We need to achieve viral suppression. We want immune reconstitution, improvement in clinical status. We need to avoid deaths. So even, especially those that are severely immunosuppressed, they have very low CD4 counts, needs to be expedited in the switching to second line. You don't really have to wait. Remember, this can help, switching therapy can help to also optimize adherence, especially if the drugs that the individual was on, they are having side effects, for instance. It's also important to know that the more someone stays on an effective therapy that is not working to the maximum, the more they'll start accumulating drug-resistant mutation, and you can have cross mutations because of that. So it's very important that the switching is done as early as possible. So today we wanted to go in a little bit deeper to look at the second line treatment itself and how we can pick it, choose, and so on, especially that we do get a lot of calls on this particular topic as a program. So what are the options? We know that our options for second line is either a DTG or darunavir-based second line recommendation. So those are the two that we are recommending. You can have alternative, maybe lopinavir based in those that have TB and they failed DTG. Yeah, but our regimen, it's either AZT3TC darunavir or TLD or Tafed. You can have TDF3TC and darunavir as well. You can have AZT3TC and DTG, depending on other circumstances around that case. Remember that darunavir cannot be used in those who have tuberculosis. So in our focus and quantification, sorry, this was supposed to be for 2023, 2024, we do not recommend. As we move on, you can see that drugs like atazanavir and so on should not really be used and they've been moved out of the therapy. So why are we insisting that all patients should be put on dolutegravir or darunavir-based second-line therapy? We are going to go through some of the evidence that is there so that it can help us in making the decisions when we have the patient in front of us. So the first one is drug resistance. We have a lot of drug resistance to efavirenz-based, but in our survey 2020, 2019, 2020, we did not see a lot of DTG mutations, but we are seeing that now. But remember, please, that those that failed first line for about a year, these are some of the mutations. You can see that drugs like abacavir, almost 70% of them are drug-resistant mutation, those who are on first-line therapy. So mutations are common in those that actually do fail treatment. Yeah. So this is the reason why we pick certain treatments, certain therapies, and not the other. You can say that zidovudine is rare, so it becomes not rare, but it's not as high as others, so it becomes a good choice blindly to put the person on zidovudine. But 50% have mutations to TDF. And this is just the same information. It's similar, that's those who fail at 48 months. This is like close to 5 years on treatment. If the failure still, they have a lot of mutations, but less for the zidovudine line. So, but how do you pick that backbone, the NRTI, so not NNRTIs, the NRTI backbone? Can you recycle it? Well, let's go through some of the evidence. So the first one, I think we've shared this, is the trial called the Nadia trial. Here, what they wanted to see is to see if there is the difference in those patients that are on DTG, whether you put them on TDF or AZT based as a backbone. Similarly, those are on darunavir which we are using as our second line. So does it differ whether you put somebody on AZT or DTG or TDF based backbone? Basically, and this was done in Africa here. So a number of those individuals had a K65R mutation in them. You can see it was like 50%, what you really expect, like we saw in our survey as well. And there were some mutations, few of them though, to zidovudine, again, what you expect even from our survey. But what were the findings? The finding was that those patients that are on TDF based, say with darunavir or DTG, did slightly better, and it was significant versus those who are on AZT. And so here what it suggests is that probably it doesn't really matter what background mutations that you have. We can see that it wasn't significant between DTG and darunavir if there were no mutations and had not received DTG before. So you can pick either depending on what you have, but it looks like it does matter what you use as a backbone, and there can be some differences over there. And most importantly, you can also see that those that had emergent mutations, there were some mutations to DTG, but those that failed darunavir, there were no mutations at all. There is another trial, 2DS trial done in Kenya. Again, here what they wanted to do is those adults who are on second line therapy on a PI, and they were put either on two NRTIs or not, and the others were continued on the PI, and the others switched on DTG. You can see that at the end, I'll skip some of the trials, you can see some of the slides. You can see that at the end, if you compare those that were on DTG, which is in green, in blue, and red PI, there was no much difference in the biological suppression rate. So really, you can see here that you can use DTG for second line. The other study that I would like to share with you is the Vicent trial, which was done here. This is just sample some evidence that are there. So here, it was done here at the center at UTH. A number of us participated, and the thought here was to have those individuals that are failing second line. You can see the arm B with high viral load. You put them either on TLD or Tafid, or you put them on AZT with a PI as expected. And the findings were again staggering. I'll just skip. You can see that those who are actually on Tafid or TLD did much better. If you can look at both in the PEP protocol and the intention to treat analysis compared to those who are on AZT. So it does show again that it looks like the backbone does not really matter. And when we look at the mutations in the Vicent, we find that there's no difference in biological suppression among patients switched to Tafid or TLD between those with or without NRT mutations, suggesting the same, that the background mutations does not really matter. So this topic has been extensively researched. There are other trials that I haven't shared here, the NS trial, the second line trial, and so on, and other cohorts, a review. You have the UK cohort, and a lot of other trials that show that actually the susceptibility to the backbone might not have a big bearing on the outcome. I wanted to share this trial was done by an Australian team. I think Zimbabwe was part of the trial, the so-called 2F trial. What they wanted to do here was also to try to compare darunavir and 2-NRTIs, and also just darunavir and DTG, and obviously darunavir combined in DTG is a very potent combination. You can see at the end that, oh, sorry, the slides are, your slides are a bit, yes, I think you've caught up. Yeah, so you can see at the end that those individuals that were actually on darunavir and dolutegravir did far much better than those that are on darunavir and NNR. But the most important part is to know that between darunavir and DTG, with whatever background that you may have, there is no much statistical difference. So CD4 changes were not so different. Sorry, we are rushing because of the time that we do not have. So the conclusion of the investigator here was in an open label study of efficacy of second-line treatment after NNRT, that's a efavirenz-based ART failure, DTG plus darunavir and DTG and 3TC were non-inferior to darunavir and 2-NNRT. So you can really move these drugs. There's a lot of options that you have among these particular drugs. Now, the problem that is there is we are having emergence of DTG resistance. So a number of these trials might not be very applicable because individuals who are failing efavirenz based and going to DTG therapy, but those that are failing DTG therapy, what are the options? And that's where probably we have a bit of advice that maybe the backbone does not really matter if you have to move your patients to, say, darunavir based. You can see that, say, in the Nadia, the darunavir, either with AZT or TLD, really performed, and those who are put on TLD as opposed to AZT performed slightly much better. But we do not know how long that particular regimen would last, and the concern is the resistance that we are seeing. So, and again, you also have to note that now it really looks like darunavir is much resilient compared to DTG. You can see that in the Nadia, there were some DTG resistance, but no darunavir based resistance. And these are the main reasons why we feel that most of our patients on second line should be put on darunavir based regimen. This is just an example of the patients that we have in country with higher level resistance to DTG. You can see we had a 1-year-old child over there, 11 months old child with high level resistance. And this story, we've looked at this child, it doesn't look like transmitted resistance, it's just that same drug exposure. A lot of cases we've seen, who have also, which we are going to share some of the cases that we've seen. So we've put a lot of patients on darunavir based regimen. This is our scale up. You can see that by and large, there are some provinces which are doing well, provinces which are not doing well. So provinces like Northern and Northwestern, why don't you have patients on darunavir based regimen? Because this is the preferred regimen for second line right now. And these are just examples. I hope I was successful in getting the names of some of the drug resistance. And interestingly, most of these results are patients that we've seen early this year from, and some of them late last year, from Western Province. Western Province has, I think the new results, about maybe close to 10 DTG resistant cases. Unfortunately, we lost even one gentleman towards the end of last year from Kaoma, I think from Mangango over there. Again, delays in switching, that sort of thing. So this does happen. What we hope to do, these are just examples. You can see there are a lot of complaints that you are not seeing the results. The results are there. You can send the sample will be amplified, but we do have this DTG resistance that we are monitoring, and it's an issue of concern. And Darunava tends to be almost always susceptible, and that's why we keep on singing that these patients should be switched to Darunava-based regimen in second line. So these are the cases. What we plan to do is next week, Thursday, we'll dig deep into these cases and have a symposium at our HD meeting, ECHO, where each case will look at how to handle these cases. So really, Darunava is the best of the class. In the PI, it's got the highest genetic barrier, better viral suppression, better tolerability, it's slightly cheaper, and can be used in multiple lines. And that's why we feel it's all of us should start moving patients quicker to this regimen. So with all this said, what is our guidance? So you see this, that everybody that is failing or intolerant DTG first line should be put on Darunava. Everybody that is intolerant to LPV should be put on Darunava, as long as there's no PI mutations, that is if they're suppressed. Everybody that is on Atazanava with a valid suppression, they are suppressed, should be put on Darunava. Those that Darunava should be used for children. So for children who are on PI and so on, adolescents, let's move them to Darunava as long as they're above 12 years old. Additionally, like we say, all adolescents with a valid suppression viral load on Opinavir should be transitioned to Darunava. So all facilities are expected to be using Darunava. You can see, I think I've seen these slides. So concerning the backbone to use, we still recommend that we do not use dual therapy, but we use triple therapy. And you use the drug that was not previously used. So for instance, if someone was on AZT, you use TL, TE or so, TDF. Someone was on TDF, you use AZT. But generally, you can see that this recycling can be safe in a number of cases, especially where pill burden, toxicity, tolerability are more important. We had a case, one of the poll questions of an individual who has anemia on AZT second line, but they were on TOD previously. We get that call most of the time. So what do you do? The answer is simple, but you take that patient back to TDF based regimen. Do not be scared. The evidence is a bit strong. So on those cases like that, where there's toxicity, maybe the drugs are not available, there's pill burden problem, someone, instead of being on AZT, 3TC, and DTG, you can actually, if they are struggling, because AZT is twice a day, you can actually give them TOD. So that we know from the evidence that we have so far should be working. So recycling can be done even when the new backbone is not available. Clinical judgment and expert opinion must be obtained where unclear or in a case-by-case basis. Yeah. So summary: avoid delays in switching to second line. Facilities are encouraged to move to darunavir-based. You've seen the evidence in so many trials that we have that probably that is the future, and recycling of patient could be efficacious in a few patients. Thank you very much. Again, apologies for the trouble that we had at the beginning of the session. Over to you. I don't know if Dr. Mwenya, you are able to moderate if they can hear you.
Good afternoon, Dr. Sibile. Yes, thank you so much. I can take over.
Thank you.
Okay. Thank you so much, Dr. Sibile, for that enlightening presentation. And I hope some of the questions that we had before the session have been answered. Before we go to our Q&A session, we'll just relaunch the poll questions. IT, kindly assist with relaunching the poll questions. Chatonda, could you please assist us with relaunching the first poll question? Chatonda, can you hear me?
Yes, I can. The internet is just slow. It's taking a while.
Okay, apologies via network. So we'll relaunch the polls before we go into a question and answer session. Then after the short question and answer session, we'll go into our case presentation from Mr. Confucius from Nalolo. Confucius from Nalolo, kindly get ready to do your case presentation. Confucius from Nalolo, kindly get ready to do your presentation. Apologies, network, we are unable to relaunch the poll questions. Okay, so I'll read the question. Are we able to see the screen for question 1? Okay, so you're unable to. Okay, in the interest of time, I think we won't do the relaunch of the poll questions. We'll go straight into our discussion. So we have a comment from Jackson Moore who says, a nice presentation, just applauding you, Dr. Sibile, for that wonderful presentation. Then we have a comment from Peter Singogo Clinic in Ndola where they're saying they don't have darunavir available. So probably you'll give a comment at some point. So network, I just repeat, we're unable to relaunch the poll questions, so we won't do them and we'll go straight into our question and answer session. We are having challenges. I hope that is clear. We won't relaunch the poll questions. We'll go straight into our question and answer session. So for those that have questions, comments, and clarifications, I'll allow you to do so now, just for the next 5 minutes before we go into our case presentation. Kindly raise up your hand if you have a question, a comment, or a clarification. We have a comment from Kaenda. Well done, nice presentation. Do we have any questions from the network, or the presentation was very clear? Okay, we have a hand from Kazadi. Is this Dr. Kazadi? Kazadi Kashikula, are you able to unmute your mic? Kazadi Kashikula.
Yes, thank you so much, Doc. I hope that my voice is heard clearly. Thank you so much, Dr. Sivile, for this wonderful presentation. I would like to express a concern and have some clarification on your side on the utilization of Darunava as the preferred, PI for second line. Is that utilization of the Darunava on second line have any bearing in the way we use Darunava in third line? I know that we are talking about second line optimization, but I would be very grateful to be assisted with that piece of information in relation to third line management in a context where the patient had been already exposed to Darunava on second line. Thank you.
Thank you so much, Doc.
Thank you, Dr. Kazadi. And how is the copper belt? I hope Ndola is okay. I know we had it. Yeah, you have both. So Darunava comes in two types. So you have the one for second line is combined with ritonavir, which is 450. So you give it once a day, 800, 100 combination. So 2 tablets once a day, that's for second line. Someone who doesn't have any PI mutations, they've never taken Darunava, Lopinava, or Atazanava before. If they have, they should be suppressed if that's the case. For third line, those who failed an LP, Lopinava or Atazanava, and they have evidence of PI mutations, or even those that have failed Darunava itself, depending on the mutations that they have, you can use Darunava again in third line, but the doses will be different. So that's the one that has got 600 tablets with a separate 100 ritonavir. So that's a BD, so the maximum dose will be 1,200 milligrams. So there's a bit of a difference. For second line, the Darunava we're referring to is actually the one for combine, the 450. I hope I've answered your question, Dr. Kazadi.
I think you've done justice to the question, Dr. Sivile. So we do have some comments in the chat box regarding availability of Darunava. This is the second comment. We had an earlier comment. So this is Senga Hill. Then there's a comment from Sylvia, who's in the Copper Belt. She's asking if the Copper Belt is doing genotype testing, and she previously had a patient who failed first line. They did collect a sample for genotype, but it's been over 3 months now with no results available. So has this problem been rectified?
Yes, the problem has been rectified. I think we've had a session on HIV drug-resistant testing and how to interpret and that sort of thing, which is probably not the focus for today. But the message is the struggle has been the return of results and the recording. So you need to reach out to the lab itself if you are able, but you can go through the provincial biomedical scientists as well. They are at the moment responsible for following up those results. Sometimes the results come back and they are not channeled through to the individual facilities. So there have been some challenges with return of results. But otherwise, we've unlocked the challenges that we have with having these results. You can see, that's why I had to show some results from Western Province, who have been quite active. I know places like Central Province, you still have to streamline your process of reaching out to us, to the lab, but the lab is quite functional. So Darunava is available at ZAMSA, and that's why we are having this talk, to encourage everybody to order, because we will not use a push. as in just send the drugs to your facility if your facility does not have the drugs. So right now we have close to 20,000 bottles of darunavir, and as you know, there are very few patients on this, and we know we are lucky enough that both the funders and so on, the main funder like PEPFAR, they are willing to supply us with this commodity to help us procure, this commodity, so we don't have much challenges in the commodity. It's just the systems with ordering, logistics. The drug will not come on its own. So you have to ask the district pharmacists to order, then the drug will come.
Thank you very much, Dr. Sibile, for that clarification. So in the interest of time, I'll allow Mr. Ernesto Siakanego to go ahead with his comment, then we'll answer the question in the chat box. Then after these two questions, we'll proceed to our case presentation. So we have a question from Kamuchi Manda. Can we use darunavir in someone who is HIV/TB co-infected with drug resistance to DTG? So after you answer that question, I'll allow Mr. Ernesto Siakanego to go ahead with his question, then you can tackle both questions at once.
Yes.
Mr. Ernesto Siakanego, you can go ahead and ask your question. Mr. Ernesto Siakanego.
Okay, thank you so much for the presentation. My question is, in a situation that you have a recipient of care who is resistant to lamivudine and amitriptyline, what's the next course of action? I have 3 that are actually resistant to amitriptyline and lamivudine. Thank you.
Okay, so Dr. Sibile, we have a patient that has resistance to lamivudine and emtricitabine, and then we also have this question about a patient who is HIV/TB co-infected and they have resistance to DTG. Can they still go ahead and use darunavir?
I'll start with Mr. Kamchimanda. So the answer is no. Unfortunately, you cannot use darunavir with rifampicin. You can use it with other modified TB regimens. It's been difficult for the program to get rifabutin, which would be the choice in that case. And so in this scenario, we unfortunately have to use lopinavir ritonavir, which we still have right now at ZAMHSA. A lot of lopinavir ritonavir, it's available, and you have to double the dose. We hope that in future we can have better alternatives. As you know, the pill burden tends to be much, much higher in that scenario. In a few cases, the TB therapy can be modified. So these are some of the cases where we say, please call us, because the good part with the TB program is that it has a lot of options right now. As you know, there are a lot of drugs that are used for the second line TB. I mean the DRTB, the second line drugs. We have bedaquiline, Nezolid, we have, so the options are slightly more at the moment to make that decision, but by and large, it's no. That's in a scenario where you cannot really have lopinavir and so on. Yeah, just to make everybody know that we still have options. That leads me to the case of etravirine and lamivudine. So by and large, we've gotten rid of NNRTIs in our program, except just for prophylaxis, nevirapine in prophylaxis. And so there is really no role of using them. Even in third line right now, what might not be etravirine is not probably the drug of choice that we are starting, except those who are already on the etravirine. they can continue. Yeah, but in the future, you might see NNRTI is coming back on the fore. We are entertaining the idea of bringing doravirine as an option to these cases that you are asking an NRTI. So where there's resistance to both lamivudine and etravirine, probably there are other options. Now we are leaning more on the PIs and indeed the instis to use in our therapy. Thank you.
Thank you so much, Dr. Sibile. We'll now go straight into our case presentation. Mr. Confucius Mwemba from Nalolo. I'll ask Chatonda to share your case and you can go ahead and present. Mr. Confucius Mwemba. Confucius Mwemba from Nalolo. You can go ahead and present the case. Confucius, are you able to hear me? Confucius? I can see your mic is unmuted, but we can't hear you. Confucius Mwemba from Nalolo, we can't get you. Are you able to hear me? Okay, Chatonda, kindly share the case. I can present on their behalf if they're not able to speak.
Hello?
Yes, is this Confucius Mwemba?
Yes, please.
Okay, you can go ahead and present. Chatonda, kindly share the case again.
Good afternoon, team.
Good afternoon, you can go ahead.
This is Confucius Mwemba from Narora district, particularly Moyo Rural Center. So we are presenting on a case of SS female 40, born on 6 June 1983. Was diagnosed with HIV on 6th October 2011 and was initiated on a TDF 3TC NVP on 31st October 2011. On 12th October 2017, she recorded her first high viral load. She was switched to AZT3TC Rokinava on 23rd March 2020. This was after a successive repeated session of EAC. She was later switched to TOD on 30th October 2020. She was then switched to AZT3TC DTG on 30th October 2023. This was after a series of unsuppressed VA following session of EAC. A sample of drug resistance testing was collected on 21st September 2023. This was due to non-availability of KFT facility did urinalysis on 21st October 2023, which was non-revealing. After a CD4 of 167 cells, a serum CRAG and urine alarm for TB was done on the 23rd of January 2024, which were both negative. Her EIC sessions were handled by a trained HIV nurse practitioner and a registered nurse midwife, who are both full-time ART providers.
Okay, let's get
Being-
inside. That's it.
Being inconsistent with time for taking medicine was the main barrier identified during the EIC sessions. On the social status, she's married to a KP partner currently in our care on TLD and is virally suppressed. She has 3 children who are all less than 19 years and were tested for HIV, and they are HIV negative. She earns her income farming. She was last seen on 24th January 2024. General physical examination shows the general condition was stable clinical. Her general appearance is good. The chest was clear. Cardiovascular system, S1, S2 normal. Temperature 36.1. BP 105 of 71. Weight 53. Height 165. BMI 19.5. Can you move it down or up?
Chatonda, next slide.
Okay, so these the labs for VL and the regimens. In 2011, that is 30th October, she was on TDF3 TCNVP. 12 October 2017, she had a viral load of 10,300. She was on TDF 3TC EFV and was switched in 2015. On 29 September 2018, she had a viral load copy of 1,785. She was on TDF 3TC and EFV. On 30th August 2019, she had viral load copy of 56,572. She was on TDF 3TC and EFV. 27th February 2020, she had a viral load copy of 42,867. She was still on TDF 3TC and EFV. On 30th July 2020, she had a viral load copy of 535 and was switched on to AZT3TC and Lopinava, which was done on 23rd March 2023. On 29th October 2020, she had a TND viral load and she was switched to TOD. That was she was switched on to TOD. Then 17th February 2021, she had a viral load copy of 30 and she was still on TOD. Then on 13th December 2022, the viral load rose from 30 copies to 12,159. She was still on TOD. On 6th September 2023, a CD4 count was done, which was 164, and the viral load copies of 64,381. She was still on TOD. Then on 4th January 2024, the viral load was 22,124, and she was taken back to AZT, 3TC, and BTG. Can you move a bit up? Okay, so this is the genotype result for the same client, which was done on 21st September 2023. I don't know whether I need to read the results also.
No, you don't have to.
Okay,
Where are the
so
instances?
this is the picture of the genotype results, the resistance testing.
No, the numbers.
Oh,
Do you have the next, sorry, there should be a part of the genotype which shows the exact numbers for the instance. So, and we'll discuss that later.
okay, thank you very much, Confucius. I think you can end there. So let me summarize the case. We have a female 40, RBD reactive on ART for 13 years now, and she's been exposed to quite a number of regimens. As of January this year, her viral load was 22,124. Currently, she's on AZT, 3TC, and DTG. EAC sessions have been conducted by well-trained HNPs, and she has a suppressed partner. But of note is that she has challenges taking her drugs and following the time consistently. So we have these three questions: what was done correctly, what was not done correctly, and what is the recommended regimen for our client in view of the drug-resistant test results. So before we allow our expert to answer the questions, I'll open it up to the network. So for starters, we have a question from Patricia. If adherence was identified as the main barrier, were other adherence supportive measures put in place before switching her to second line? You have that question. Confucius, are you able to answer it?
Yes. When we discovered that she had some issues with the consistency on taking medication, we had to assign one of our CBVs to do the dot on her. We have a CBV who just lives in the neighborhood where she stays. And she did that, but despite that, we still continue to having the high viral load. So we also did, we sourced the phone, the husband has a phone. So we also tried to use the alarm. We set the alarm for her when she came to the clinic, which confirmed, and also CBV confirmed that they were using it consistently. Thank you.
Thank you very much, Confucius, for those comments. Do we have any other questions from the network before we answer the questions? We have a hand from Chinsali. Chinsali, you can go ahead and ask your question.
Good afternoon. Am I audible, madam?
Yes, we can hear you.
Thank you very much. It is a nice case study or presentation. I just wanted some clarification on the pattern of viral load monitoring. I have seen that the timing which was there between the first TND viral results and 30 copies there, we see that we have about 4 months elapsing. Then thereafter, from 30 copies to the other value, we have got 10 months. So I wanted to understand what guidelines were being followed, or what could have been the issue for us not to follow the expected timing for viral collection in this case. If we wanted to for example, even monitor this client maybe on a 3-monthly basis or 6 months, or maybe yearly after seeing that. Then there was something which was missing on the switching to TLD from AZT regimen. You see there that when they finished the EAC session, they just told us in the notes that they switched to TL, they switched to AZT, then again they switched to TLD. So I wanted to find out, why didn't we switch to TLD from TLE? Why didn't we replace the efavirenz with dolutegravir before actually getting to AZT? If it is because of the results of the genotype we received, then I was wondering why we got back to TLD, because then we would have been shown that most of the drugs were resistant to the virus, if I saw correctly the results. Thank you.
Okay, Confucius, are you able to respond to those questions? Just go back to the slide on the timeline, and then Confucius, you can respond to the questions. There's an issue of your timing of the viral load sample collection. Hello, Confucius?
Hello?
Yes, we can get you. Are you able to respond to those questions? And then please be brief as you respond. We're running out of time.
Okay, thank you. I start with the first one. He said on the switching, why didn't we switch from TDF3TC to EF3? Instead, we went to AZT3TC. So it was in reference to the previous, when you look at the previous VIO results that this client has had, they were high, and the suspicion of failing on TDF3TCF3 is the one that prompted the person who was attending to this client to switch to AZT3TC and lopinavir. And in reference to that, as you see, this client, the moment they started taking this regimen, they suppressed from 42,000 to 500, which proved that it was worth doing. Then on the timing on the VIO, yeah, what happened here, we corrected the first VIO, 2020, that was October 29th. This result delayed to come. So it prompted us to recorrect another one. So after recorrecting the other one, because we saw that it was taking time to come, then when we received the latest one, that's when also the previous one popped in. So we just entered it there. Not that probably we didn't know what was supposed to be done. It was because of the delay of the first VIO result that was corrected. Thank you, and over.
In the interest of time, I think we can now tackle the questions. What was done correctly? So I've seen we have some comments in the chat box that seem to be responding to both question 1 and 2. So we have a question asking why it took them so long to switch the patient from TLE, and I think he's talked about the issue of receiving results. The results came late, but eventually they did switch the patient. Did the providers respond to the dictates of the genotype results? So now that they have the genotype results, I think they will be able to do the right thing. So this comment in October 2020, this recipient of care had TND about 4 months, repeated the viral load. What made you bleed her in 4 months? Thank you. So I think that would be what was not done correctly. So what was not done, not collecting the viral load as recommended by our guidelines. Okay. The third question, what is the recommended regimen for our client in view of the drug-resistant test results? So maybe Chatonda, could you please go back to the previous slide, which gives us the thank you. So the network, you can go ahead and give your submissions before I allow Dr. Sibile to give his comments and wrap up today. Network, the floor is open for us to discuss in view of these results. And I think Dr. Sibile mentioned that we still have a certain part of the results that's missing, so perhaps it would be difficult for us to comment on that. So maybe what we can do now is I'll allow Dr. Sibile to respond to the questions and give his final comments, then we can wrap it up.
Thank you. Are there some other experts on the call?
Unfortunately, at
No,
the only
I'm alone, left alone. So thank you. Chatonda, you can go back to the slides, the first slide, previous.
Next,
Oh, the slides with the viral loads, probably.
the timeline.
The timeline slides. Yes, thank you. So thank you, Nalolo. Brilliant. That's from Nalolo, right? Yes, brilliant presentation. And we need to discuss more on these cases. We are seeing a lot, and there should be a lot of cases like that. And we are going to see a lot of these cases. We need to make decisions as a program, as a team, how we are going to treat them. So the first thing, definitely brilliant that you did the viral load, caught up the resistance early, or the high viral load early when it was still in the 10,000s, around there, 1,000. I'm sure you are doing your ESC, though the timeline seems like there was a bit of delays. Maybe that's why there was an accumulation of those mutations. But I would want to also recommend you, when you switch this individual to AZT3TC and lopinavir in July, then later on they were suppressed and you took them to TLD. I think this was a good switch. It's correct. At that point, one would expect that this individual should be able to suppress the therapy, especially that they were suppressed at that point when you are switching. Now, you can see that this individual is not going above 100,000. So these are, and the history suggests that she's a non-positive partner. They're both on ART. She's a farmer from what we got, a 41-year-old. Now, she seemed to be taking the drugs, but not consistent. And these are the individuals that typically will give you very bad genotype, as you can see. So from the onset, if you have somebody who is hitting very high viral load, 500,000 and so on, you start thinking this person just stops. They tend to have a better genotype results than somebody like her, who probably never gets very good amount of drug levels in the blood. But the fact that at some point they were suppressing, it shows that if they can be consistent, they can suppress. It takes us back to the question, to some of the comments of adherence. It's not still saying this is probably what you didn't do too well. I know you've said experienced nurses and so on did the counseling, but from our ESC, we would have loved to know what exactly is the issue beyond just being inconsistent. Why is the person inconsistent? Probably that is the question. So we don't seem to have gotten the root cause. Looks like there's no biological reason to say maybe they have a gastroenteropathy where they can't, you know, they can't absorb the drug, that's why they keep on failing. No, because at some point this individual was able to suppress, but they seem to have a habit that's making them not suppress. And that's why there is it. So definitely the first recommendation that we have is better counseling. We go back to the individual. Believe you me, if you do a better counseling, issues will come out. What are the background issues that this makes this patient be slightly lukewarm in the way they are taking the drugs? They take the drugs sometimes, they don't take sometimes. They take the drugs sometimes, and this is what you see from this picture. So still we insist, especially, you know, somebody who's had treatment failure before has a risk of treatment failure again, unless those issues why they were they failed were solved. And here, when this individual failed first line, we are not given that story that whatever the reason that made them fail was sorted out, was rectified. So we need to go back. How is their lifestyle? What is their education? Do they understand? So it needs thorough counseling. I'm available. We can have a call with the facility, even when the client is there. We can have a call, even a Zoom call. We participate in that counseling session so that we can go to other personal issues that the individual could be experiencing. So I really think there's still a counseling issue that hasn't come out because the report of why they've been failing is not convincing. They took TL for 6 years, TLE for 6 years. We know the median time is maybe 5 years, but still one would think someone should be able to suppress for longer because it's a bit of a durable drug. But you can see that TLD was just for less than a year. For you to knock it off, even in clinical trials, you wouldn't see that where people had documented mutations. Yeah, so what are the options after the counseling is exhausted? Obviously, this individual needs to go on darunavir-based regimen. I would like to see the genotype for the mutations that were for integrase strand inhibitors themselves. Sometimes we can give something like TLD plus darunavir, which you are making a third-line regimen. The good part at that point, this individual doesn't need to come to Lusaka or go to some third-line clinic. You have the drugs in the facility. So you give TLD and darunavir. Sometimes they might need to double the dose of DTG itself, depending on the mutations that are seen for DTG, the INSTI mutations. In other words, the good news for this individual without PI mutations, they do not necessarily need to travel to, they can be treated in Nalolo. Nalolo should have darunavir. You can order, it can work. We say that you order if you don't have it for this particular individual. We need to maybe put this patient on therapy in the next 1 week or two. Effective therapy, the CD4 is below 200. she has advanced HIV disease, so she's in the red. This is a patient you can lose any day. They can come with crypto, with whatever, any day, and you can lose this particular individual. We advise septic prophylaxis at this point as well. We encourage that even if the AHD screening was negative, still after 3 months, if that was 3 months ago, you should repeat them as well. That is the LAM and the CRAG, because these things can come up in that regimen. So I can see someone is saying she goes to the salvage therapy, salvage regimen. Yeah, in a way, though we are trying to avoid that term. So what will happen, it will be 3 tabs OD. So it won't be a lot of tabs. It will be just 1 tab of TOD and 2 tabs of darunavir, ritonavir in the morning, which should be okay. But before all that is done, we still need to revisit the counseling story. So the presenters have not exhausted or reported an exhaustive story of why this patient failed. We know they were inconsistent, but why were they inconsistent? Sorry, Dr. Mwenya, for that long response. I don't know if they have any response. Confucius?
Okay, he's still on the call. So thank you very much, Dr. Sibile, for that feedback. Confucius and the team from Nalolo, please get in touch with Dr. Sibile. I think his feedback is very, very important, and he's given you at least what you can do immediately. You need to call the patient, get in touch with them at least within a week, and do what he's asked you to do. Confucius and the team from Nalolo, are we still on the call?
Yes, please.
Okay, please get in touch with Dr. Sibile. Otherwise, we are so grateful for the case. It's a very good case that we can learn from, and I personally have learned a lot from the case and even from Dr. Sibile's presentation. And the take-home message to each one of us is that darunavir is our game changer. It's available in the country. For those that haven't ordered, please order the drug. It's available at ZAMHSA. Let's do what we can for our patients so that we do not lose them from HIV-related illness. Thank you so much to everyone that logged into today's session. Apologies for the initial hiccup that we had earlier on, but I think now we'll have to end our session. Otherwise, it was a very good session, and we have learned a lot. Thank you so much, Dr. Sibile.
Thank you, players.
Thank you, Chatonda, and thank you our team from Maryland for coming. And thank you to everyone that logged in. I'm Dr. Lungwabungu from Lusaka Provincial Health Office. Bye and have a good week. Thank you.
Bye-bye.
Bye.
Bye.
Bye-bye.
Bye.